Webinar entitled Getting Your Patients Screened, Ideas to Increase Colorectal Cancer Screening. My name is Fran Oddie. I'm the Senior Quality Improvement Facilitator with the QIO at Telegen. We have a quick polling question for you to let us know how many people are viewing this webinar. Pardon? Yeah. Can you please present or display the polling question? We have 15 seconds to answer this question. Thank you for your responses. Okay, thank you. We will be muting your lines during the presentation, but the chat box is open for you to answer questions in at any time. Those will be monitored, and we'll ask those speakers the questions at a later point during the presentation. So I am so very excited to introduce you to today's speakers. First up is Dr. Michael Potter. He is a professor in the Department of Family and Community Medicine at the University of California in San Francisco. At UCSF, he is director of the San Francisco Bay Area Collaborative Research, a network of researchers and practitioners that collaborate to develop and evaluate innovative practice interventions that can improve patient outcomes in diverse clinical settings. Dr. Potter is the developer of the award-winning Flu Kit program, which leverages the time of annual flu shots as an opportunity to increase colorectal cancer screening. The Flu Kit program has been recognized as a research-tested intervention program by the National Cancer Institute and has been promoted nationally by the American Cancer Society. And our second speaker today is Victoria Brenton. Victoria serves as the Iowa Get Screened Reporting and Coordinating Manager at the Iowa Department of Public Health. She joined this role in March of 2013 after working for nearly 3 years for the department's Comprehensive Cancer Control Program. Before her time at the department, Victoria managed the Iowa Department of Human Services Ticket to Hope program. She has worked for several U.S. senators in Washington, D.C., including Senator Tom Harkin, where she represented healthcare, disability, and education policies. She is a graduate of Iowa State University and is currently working on her Master's of Public Health at Des Moines University. So thank you, Dr. Potter and Victoria, for giving your time today to present. So like I said, the chat box is open where you can enter questions at any time, and we will be monitoring that. And at this point, I'd like to turn the presentation over to Dr. Potter. And Dr. Potter, if you could unmute your line, that would be #6.
Hello?
And we'll pull up your presentation. Yes, hello. Perfect.
Okay, so I'm taking you guys on a quick tour of our the Flu Kit program, and if you can go on to the next slide, I can show you the objectives, which are to describe the need for different approaches to address colorectal cancer screening disparities than what has been tried before, and to describe the evidence that we have for the Flu Kit program, and then to review the Flu Kit materials and discuss ways that you might implement them or make use of them. Next slide, please. So just to review that colorectal cancer is the third leading cause of cancer, of life-threatening cancer in adults, with over 140,000 cases every year. And it's actually the second leading cause of cancer death in adults, with over 50,000 deaths per year. And mortality has actually been reducing fairly dramatically over the last 35 years. And in fact, there was even just recently an article that came out suggesting that colon cancer has decreased by about 30% in the last decade. And half of this reduction is believed to be due to screening. Next slide, please. So compared to other types of screening that we have, it's one of the most effective. And it's something we have to be doing for everyone. Just to review how colon cancer screening saves lives. Just to remember that for most of them, cancers progress from, the colon progresses from being normal to developing a small adenoma or polyp and proceeding to cancer, usually taking several years, or at least 10 years, to go through this sequence. And so the goal is to find and remove the larger polyps and early-stage cancers before they spread. Next slide, please. So which tests should we be using? I just wanted to review the U.S. Preventive Services Task Force guidelines, which are from 2008 and are fairly similar, actually, to the American Cancer Society guidelines as well. There are basically three approaches that are recommended. Fecal occult blood tests annually, preferably using high-sensitivity tests, and we'll talk about what the high-sensitivity test is in a little bit, or flexible sigmoidoscopy every 5 years with intervals, FOBT every 3 years, which is another option that can get similar results but is not used as much just because flexible sigmoidoscopy is not too available these days. And then colonoscopy every 10 years, which is by far the most common screening modality used in the United States at this time. The ages to test are between the ages of 50 to 75, but really you can continue after age 75 if the patient has a life expectancy of 5 to 10 years. Obviously, for people over 85, there are very few people with a life expectancy that goes beyond 5 to 10 years, so it's really not recommended to screen in that age group. Next slide, please. And what are we screening with? This goes back to what I was saying about colonoscopy being the premier approach, the most commonly used approach to screening. You can see that between 2002 and 2010, we went up as high as 65% of adults being screened with lower endoscopy, which is almost entirely flexible sigmoidoscopy. But at the same time, screening with home stool tests has declined. It's almost in half, from 21% within the last year down to 12% within the last year. So the real question is, in this age of colonoscopy that we have, where that's sort of being pushed as the premier preferred option, and where the evidence doesn't necessarily show that it is the only effective option. What about those people who don't want to have a colonoscopy because they're too invasive? Or what about those in our underserved medical settings who don't have good coverage, or any coverage perhaps, or who have limited access perhaps, such as those in rural areas? What are we going to do? Because how are we going to get to 100%, given that there's probably a good proportion of the population that just really won't be going for a colonoscopy? So, next slide, please. So, there are disparities, and these disparities actually have been growing in some of these groups as the rates are higher for some of the more privileged groups. You can see that there's an age disparity. People over 65 are much more likely to be screened. Whites and blacks are about equally likely to be screened, but Hispanics, those without a high school diploma, anyone who's foreign-born, no source of care, usually like no primary care, for example, or have no insurance, those are groups that are much less likely to get screened. And from my understanding, that many of you have populations that reflect those groups. Next slide, please. We need to have some realistic strategies to address those disparities. So what is the rationale then for clinical teams to emphasize and actually not just promote, not just offer FOBT as a sort of a second-class test, but actually promote it as a co-equal option consistent with U.S. Preventive Services Task Force recommendations? It remains an effective, inexpensive, and essential component of our national efforts to increase colorectal cancer screening rates across all populations. And it can be provided, it's very easy to provide. It can be provided with algorithm-driven care by individuals with limited clinical training. You don't have to wait to see the doctor to do it. They can be, sent in the mail or provided by a nurse or a registration staff or a health promoter or anything like that. It doesn't require a lot of fancy training to do. And then if you are able to do this with some sort of organized outreach, not just waiting for the doctor to order it, it complements the work of primary care. It allows for you to reach people who don't come into primary care maybe regularly. It frees up the primary care team for other important activities. And it also supports the primary care doctor because there's more likelihood if the team is talking about it and promoting it, that when the patient hears about it or gets it ordered, they're more likely to understand and know what to do. And be ready to accept it when the doctor does offer it. Next slide, please. And then just to review a little bit about which tool test to use, and we want to avoid using the lower sensitivity tests, and that's the most commonly used ones in this country still are the lower sensitivity tests, primarily tests like Hemocult-2 or Cholescreen. These tests have lower sensitivity than other tests. There is only one brand of high sensitivity guaiac test, and that's called Hemocult-Sensa, by the same company that makes Hemocult-2, so I don't actually know why they're still promoting or providing Hemocult-2 when you have a better test that costs about the same. It's a more sensitive test, and it's a similar cost, but it does still require dietary changes, and it does have a relatively high false positive rate, meaning that if you use that test, you may generate more colonoscopies due to the abnormal tests. And then the other option are the fecal immunochemical tests, or FIT, and I think those are rapidly becoming the standard of care for stool testing in the United States. And any community health center that really wants to do high quality screening without too many false positives ought to look very closely doing FIT testing and replacing their guaiac test with FIT. The nice thing about it is that it doesn't require any dietary restrictions, so patients are much more likely to find it easy to complete and much more likely to return them when handed out without delay. And usually they only require 1 or 2 samples. And the kit that is most tested is actually the single sample polymedco kit, which can be offered through a laboratory or it can be there's a version that can be developed in the clinic. I think the brand name is called OC FitCheck, CHEK. And then the other brand that has a fair bit of research behind it is the INSURE test, which is a 2-sample test, and Hemocult ICT is another one, ICT sensory immunochemical test. It's another brand that is relatively frequently used. But we think most of those tests are about the same, so the idea would really be to choose the one that works best for you in your setting. But I strongly would recommend any of you who are using the old-fashioned guaiac test to either switch to Hemocult-Sensa, which is a more high-sensitivity guaiac test, or to a fecal immunochemical test. Okay, next slide. So this is a slide about from IRENE, which is Iowa Research Network, and it just underlines that in Iowa, more than half about half are using the guaiac test, usually the low sensitivity brands. Only 39% were using FIT, and the remainder of the doctors didn't even know which kits they were using. So there's a need really to reinvigorate our approach here, increase the quality, so that when we offer these tests, when we promote them, we know that we're doing a good job and we can stand behind the results. Next slide, please. Okay, so the rationale for pairing flu shots, FOBT or FIT with flu shot activities. And this is really, it's a screening opportunity for individuals who haven't been reached by other methods. It's an efficient way to bundle preventive services, so your team is already gearing up for a campaign for flu shots. It gives you a chance to get everyone involved in colon cancer screening for a fixed period of time, especially, and I think it's especially good for settings where you haven't really done a lot of cancer screening emphasis on this, or a lot of your team members may not be aware of why FIT testing is important, or where maybe a lot of your patients aren't aware of it, and they need the message that just like a flu shot, we need to get these stool tests done every year. It doesn't replace trying to do colon cancer screening through other methods or at other times of the year or through mailed outreach or other things that you might want to do. But a lot of times the time of flu shot is a time when you get a lot of people together and you have a health campaign, and it's a very nice way of adding something important on. Next slide, please. So this is San Francisco General Hospital, which is where I did my residency training, actually, where we first tested this program. Next slide. Next slide, please. And so it's a very multi-ethnic population. People speak multiple languages, and we developed a poster that we put up in, with these very simple messages. Flu is preventable, colon cancer is preventable, yearly home tests are easy to do, yearly home tests to save your life. All our doctors and nurses recommend colon cancer screening for healthy men and women between the ages of 50 and 79. This came in just a little bit before the latest recommendations that say 50 to 75. And when should we get tested? We'll tell you today. And these were just very simple messages, kind of tested a little bit with our population about what would motivate them. The recommendation, the enthusiasm of the staff for the testing, and not just the doctors, but the whole clinical team makes a big difference, especially when the support staff is often from the same community as the patients, more likely to be. If you have a ethnically diverse population, the patients, a lot of times in clinical staff, at least in this setting, we have medical assistants who actually work from the same community and spoke the same languages as the patients, and that not just from the doctor, but from someone in the community who's there as a respected health professional. The medical assistant can also be a powerful encourager in terms of getting people to get screened. So we have that in different languages. You can see there's a Spanish, Chinese, Vietnamese, and Russian. Those are the most common languages in the population. And you can adapt these messages for your population. I would encourage you to do that. Next slide, please. And so we actually did a randomized trial. We randomized some days when we had flu shot clinics to just getting flu only, and then on other days we had them offer flu with stool testing. And at that time we were using the low sensitivity test, which is actually harder for patients to complete. And the baseline screening rate in the clinic was around a little over 50%, and you can see that we were able to get that rate in the flu echo BT arm of over 80% by offering the kits with instructions and providing telephone follow-up, and compared to not really that much change in the control group. Next slide. And based on that, we were able to apply for funding to test this further. We had a grant from the Department of Public Health in San Francisco, a couple of grants to work with Kaiser in Northern California. We even did a little pilot testing of this in Walgreens Pharmacy, just mostly as a concept in Walgreens pharmacies here, which I think is another untapped opportunity to think about this type of intervention. Next slide. So in the public health clinics in San Francisco, where they don't typically have flu shot clinics, but they have a season where they do really promote flu shots. So where someone kind of walks in the door, and one of the first things that happens is after registration, they get asked, would you like a flu shot? And basically the intervention there was during that time when they would come in for primary care, and the staff was already kind of proactively asking them about flu shots. We tried to get them to ask about stool testing. We provided a lot less. This is a lot more real world in terms of, we were not on site to watch what they were doing, and they had the choice of how and when they would do this, and we didn't mandate that they do it every day if they were short-staffed. But we still did this sort of randomized control trial where we asked them to do it on some days and not others. And next slide, I can tell you and we did not do telephone reminders, which was, I think, part of the helpful part in the first intervention. So the next slide, can you see that? So you can see that the screening rate, though, in the intervention rate still went up significantly from 32% to 45% with just one season of trying this. The next slide, please. And then there were lasting benefits, because then I think this is where the intervention can be extremely powerful, is that the clinical consensus research part was over. Everyone in the clinic really knew how to do colon cancer screening in these clinics, and they kind of took this under their own steam and decided, this is really important, we need to do better. And they started expanding their flu shot outreach and their colon cancer outreach, and this was outside of the research, and you can see that, a year later, more flu shots were given and more colon cancer screening was provided. And universally, these clinics indicated that what really got them going was the introduction of all of the activities and support provided by the FluFit program to really just get them to focus on what they could do for colon cancer screening in general. A lot of them did continue to do FluFit programs, but it spilled over into standing orders, lots of other interventions. Some of them started doing telephone calls. Some of them started providing incentives to patients. Some of them started switching their kits over to FIT. But you can see, the number of people getting screened almost doubled over the next year. So that was a nice sort of unanticipated benefit. Usually when researchers go away, the improvements go away. But here in this setting, for some reason, maybe the ideas kind of stuck. Next slide, please. And we also did this at Kaiser, and you can see this is a line of people getting flu shots at Kaiser, so you can imagine what kind of an opportunity this is to reach people as they walk through a line with colon cancer screening. And the trick here was how to get people going through quickly, how to quickly assess who needs screening and get them the kits. Next slide. So we developed this system whereby when they would register, they had the registration clerk would check on the electronic health record and could very quickly tell whether or not the patient was due for a FIT kit. And this is someone actually handing a patient a FIT kit just after she's registering and just before she got her flu shot. So we tried this as a pilot study, and then we got funding to do this on a larger scale at Kaiser. Next slide, please. And we did this in five settings. Again, they kind of did it on their own. Next slide. And this is among patients who were due for screening. So if they were in the FluFit arm, 29% of them were up to date with screening 3 months after walking through the FluFit arm, whether or not the patient actually got offered a kit, because again, remember, they didn't always get offered a kit if the staff wasn't there already, and also they had to return the kit. But 29% were up to date of that population versus only 15.2% were up to date in the flu-only arm. So that was very impressive to Kaiser, because they're really trying to get their rates over 80%, and actually they've achieved that goal at this point. They already do a lot of stuff with mailing them out to patients on their birthdays, and several times, phone calls and everything. They were very impressed with this intervention. Actually, even when they were doing a lot of outreach, this intervention actually they could catch people who they weren't catching through other methods. And they felt that it reinforced their message about getting the test every year. Next slide. And in fact, they have disseminated this to many of their other sites in the San Francisco Bay Area, and it's spreading to other Kaisers across the country. And in fact, we developed a webinar for them, and they even have training sessions, and they have a quality. They have teams that come once a year to learn how to do flu shot campaigns well, and they've incorporated how to add preventive services like FIT to the flu shots there as one of their best practices. Next slide. And then we did try this just the concept of this in moving it into the community, because as you know, many people see pharmacists more than they see primary care, and pharmacists are very trusted, and pharmacies tend to be very trusted, and a lot of flu shots are given there. So we just, next slide. So we just, we didn't really engage the pharmacists so much because we realized that there would be a very small grant, but what we did was we just set up a station next to where they were getting the flu shots, because these Walgreens had flu shot campaigns. And we enrolled some patients, and we offered some patients fit, and some other patients we gave them education about screening and told them to go talk to their doctor about colon cancer screening if they hadn't. And I think the key point here is that patients are receptive to either approach, either getting education about cancer screening or getting a fit test. And that, overwhelmingly in both groups, patients felt that pharmacies should educate patients about colon cancer screening, and pharmacies should be able to provide fit kits to patients who aren't getting screened in other ways. So I think this is a huge opportunity if we can find a way to engage pharmacies to do this in a way that fits their business plan and allows them to have a communication up and back between the primary care provider to make sure that people get the follow-up that they need. Next slide. So, and there are other examples of these community-based carings. It's sort of become trendy now to offer preventive services together. So, getting a fit kit with your mammogram, getting a referral to colonoscopy when people get their mammogram. So there's specific things tried in Michigan. Getting flu shots and mammograms together. That's another one. There's even been some things where we're trying to pair health interventions with voting booths. People are doing their civic duty, and when they vote, maybe they're being receptive to things like also getting a flu shot if it's in the fall. Maybe there's other preventive services you could offer at the same time. And again, in Australia, actually the national program for providing colon cancer screening is paid for the government actually provides fit kits not through primary care but through pharmacies. So it is interesting to sort of start thinking in a public health way and outside the box about how we can promote how we can be proactive both within the clinic and within the community about offering colon cancer screening to those who are unscreened. Next slide. So in conclusion, these flu-fit programs, they add to other efforts to increase colorectal cancer screening. They can be implemented in diverse settings. They're effective for diverse patient populations. In that first study, most of them do not speak English as a first language. Very few, white European people of white European descent. So it really works for very diverse populations who may even be less familiar with screening. Often those populations actually would prefer as a first thing to do something non-invasive. They're a little less trusting of invasive procedures for when they feel healthy. I think I would say is that to not just assume that if you decide you want to do a flu-fit program or do colon cancer screening, a better job of it, that it's going to be easy to implement, because it's just like probably the first time people started doing flu shot clinics 30 or 40 years ago, a lot of logistic issues had to be figured out. How do you store the vaccine? Who's going to do it? When are you going to do it? What are you going to say? What if there's a side effect? All those things that you had to think about with flu shots, the logistics of it. You have to still think about those things when you introduce something new, like even something relatively simple like the stool test. You need to make sure people are educated, trained, that you have a protocol for following up, that if the test is abnormal, that someone's going to get the result and the patient will be navigated to colonoscopy. All those things have to be figured out. And so, but those are things that we have to do anyway. So if you start a program like this, it can be a good way to gear up your staff to do all these things the right way. And finally, it is an example of effective bundling of preventive services, because probably when you think about what what are two interventions that could save the most lives that are relatively short and easy to do for patients over 50. Flu shots and colon cancer screening come up very close to the top. So for clinics with a very strong public health orientation and wanting to provide services that will truly make a difference, it makes a lot of sense to pick a couple things like flu shots and colon cancer screening and offer them together, because I think it can be, these efforts can therefore be synergistic. Next slide. So we have a website. It's called flufit.org. You can just Google that and you'll find your way there if you don't remember the exact URL, but just you can Google FluFit. The American Cancer Society also has taken some of our materials and developed a downloadable manual. We have videos, we have training materials for staff, patient education materials, demonstrations of the project and how it works. We actually have links to the ACS website, and we have a link to our program's been evaluated by the National Cancer Institute and by IACRQ. I can show you, and also some of our research papers, so that if you're interested in evidence about the program, more details about how we did it, you can see that as well. Maybe you guys want to take this over to the FluFit website, and I can just set it up, and I think before I run through it, I can open it up for questions, and then we can go through the website and talk with people, show people what they might be most interested in. So that's the one, yeah. Do you want to allow other people to ask questions, if there are any? Hello?
Yes, Dr. Potter, question.
I can't, I'm not hearing you too well. Hello?
Yes, Dr. Potter, there aren't any questions in the chat box yet, but if anyone has a question that they would like to ask, feel free to do so.
Okay. So this is the website, and you can see there's a video for maybe there's a video there that you can actually click on. It's 7 minutes long. It shows how the program can work in community health centers. In this video, they're actually using the GUAC test. So some of the particulars of how the kit is being provided may be different, but I think it should give you confidence that you can do it. In fact, there's one woman in there, one health center in San Francisco says, if we can do it, anyone can do it, because she's talking about how few resources there are and how busy they are. And I think it's a nice introduction. If you want to scroll down, you can see the bottom of and you can see there's also a video about how it works at Kaiser. If you want to go back up to the top, or actually scroll back down, please. And then you see where it says Program Components and Logic Model. You can click on that, download. And then you can see that's a little hard to see, but you can print that out. It sort of shows you the sequence of how you might organize it. You can go from program planning and advertising, figuring out how you're going to do it on an everyday basis, figure out how you're going to track, make sure people completed their kits, and make sure that the results get followed up. So I think that's an important framework to think about how you're going to do each of those roles. We want to go back to the website. And then just want to show you the American Cancer Society Flu FOBT program down in the corner, and that's their implementation guide. They actually put together a very nice manual, actually using our materials that then were adapted by the University of Colorado, and then putting the ACS branding on it. And that's sort of like for those of you who don't like navigating a website, you can print that out and hand it to someone, and they can put it in a binder, maybe at the nurse's station or something like that. You want to go back? And then go up to the top, and you can see we have these other categories: why to do it, how to do it, staff training, program materials, frequently asked questions, publications, and contacts. So we can just go through quickly under why to do it. Do you want to click on that? Can you open that? Is it not opening?
No, it's not opening.
Well, that's something I should see if I can. I wonder if that's something that's wrong on my side, because it was just updated. Go under how to do it. See if that works. Okay, so that works. And so there are 5 steps. You can click on expand all, as you can see it, the whole thing. And so just goes through a lot of the stuff that I went through on my slides in more detail. You can also go up to the top, and you can download that document. So that's something you could also print out if you don't want to read it on the screen. You can go to staff training. Same thing, we've got 5 key elements, again going over a lot of the things that I went over, and you can download it. Next, go up to program materials. This is the section that I think most people make a lot of use of, and here we've included, for those of you who are setting up a flu shot clinic for the first time, it also gives you the CDC guidelines on who should get a flu shot and how to give them and all that. The U.S. Preventive Services Task Force guidelines for colon cancer screening if you need access to that. We also have another reference which I think is very useful, which is the clinician's reference, FOBT clinician's reference from the National Colorectal Cancer Roundtable. You want to click on that one? So that talks about the different tests and the evidence behind them. That's a very useful resource if you're trying to pick a test. You want to close that? I just am showing you. And then also, I put together a little blurb on some of the brands in case, which is not, I'm not on being paid by any of the brands. This is just based on my experience working with them and my knowledge of the literature. But it tells you about a little bit more about how the tests are done and how much they cost and how much they're reimbursed and all that. Keep sliding down. There's some materials that you can use, some posters. Notice that they're in mostly Word documents, and they're up there as Word documents mostly because we figured you would want to adapt them for your setting. So there's some sort of templates that you can play with, and so you can put them up the way you want. Keep sliding down. So you can figure out, we have an algorithm about who if you're going to ask people who needs a kit, they haven't had a colonoscopy in the last 10 years, they haven't had a fit in the last year, that's how you would tell. And sometimes kind of little algorithm that then you can give to your staff so they can remember. Talking points, I think that can be really helpful, how to get staff to be enthusiastic and motivate patrons to want to do it. And then we have different, it's depending on which brand you use, we have instructions that are in different languages, which may be helpful. And over on the right side, we actually have instructional videos. So if you look at FIT, for example, we have the polymedco test videos in all these different languages of how to use it. And some of them are dubbed, and the quality is not incredibly high, but they're about 3 or 4 minutes long. And they can be really useful. You can put them on your computer while someone's preparing the flu shot for them, or while they're waiting in the waiting room. You can actually have them view this video. It gives them, for people who don't read that well, it kind of walks them through why they should get colon cancer screening and how to do the kit. You want to scroll down some more a little bit, and we'll be almost done, I think. We have sample postcard reminders. We have a sample result tracking sheet. You want to click on that one? That can be a useful, I think. I hope that's what it is. If that takes too long, so this is just like if you get patients who complete you're trying to keep track of it. A lot of people, you're going to do this online or with your electronic health record, but not everyone has that to help you track, if they had their FOBT and that if it was abnormal, how are you going to make sure they got their colonoscopy? You can keep track of it with this form. You want to close that? And then And then the other thing, the log sheet, you may want to develop some version of that. So it's right above where it says sample flu set log sheet. Up a little bit. There you go. And this is something that if you're using a paper log, like these clinics were that we've worked with in the health department here, where they came in, something that, we're going to offer the flu shot, it allows the staff to mark whether they were eligible to get a flu shot. Actually tells them what the criteria are, whether they were eligible, and then whether it was given. So that allows you to have a record of, if you don't have any electronic record, of who got the kit and what kind of follow-up they might need. So that can be a really useful thing since people are used to doing this sometimes with flu shots already. All right, so close that one. And then you scroll down. And again, they have a trainer set of slides for, so you can do your own presentations to your staff. That's something the American Cancer Society developed. And then a manual that's, they have actually the American Cancer Society has a FOBT website. You want to click on that? And again, so we're linking up and back with them because they're doing a great job of promoting this program and actually have done some wonderful, they're generating a lot of new ideas and experience with how this program can work. And I'm very proud of the program that it was seen as something that the American Cancer Society has wanted to endorse and promote. So that's another resource way to get in through the American Cancer Society. You want to close that? Another place to go, you want to go back up to the top. And then we have, I'm not going to ask her to click on that frequently asked questions, but publications and contacts. Go back to the home page. And I just also wanted to point out, if you click on the blue area where it says Research Tested Intervention Program, that's another really nice, probably maybe the best place to go for information about the program in terms of an official evaluation. You can scroll down and you can see this is one of 10 programs that the National Cancer Institute has endorsed as a research tested intervention program. They feel that it's very well researched. That has, obviously it's not going to get you to 100% screening, but it's moderately effective and easy to disseminate. This is one of the highest scored colon cancer screening programs that they have there. And if you scroll down a bit, they have summaries actually of the program, of how they did their evaluation, and also of our research data. All our papers, most of our papers are summarized there, and the data and outcomes that they have. So that's just another nice place to go. And then go back and you can close this one, and then go back to fluset.org. There's one other, the AHRQ news piece actually has the story of how the program worked in one clinic here at Chinatown Public Health Center. I don't know if you can go back to the FluFit webpage. And it's just, I think it's a nice story. Let's see, if you go down to any agency for healthcare, underneath where you have that click before on the blue, yeah. And you can see there they have a very nice sort of just case study of how it worked in one clinic. So that's all I had, and I know you want to have time to talk about other things. So I'm going to stop there.
Thanks, Dr. Collier. We do have one question.
Okay.
It's asking, how did you come up with this idea
line.
originally, and do you dream about public health interventions with it as well?
Unfortunately, I couldn't hear your question because my phone was making some other sound.
Okay, can you hear me now?
Yes.
Okay. The question is, how did you come up with this FluFit idea originally, And do you dream about public health intervention?
I think the idea came up right around, I was actually kind of casting about, must have been about a little more than 10 years ago about, what can we do to get more screening because it's so hard to get people to do FOBT, and we were actually trying to get clinical people, we were saying, we should just have standing orders and tell the nurses to offer it every day. That a patient, every time a patient comes in, they should be checking to see if they're up to date, giving them the kit. And the feedback we got was, are you kidding me? We don't have time to do that. We have so many other things to do. And so it was like, well, what could we, what if you could do it once a year, or something like that? What if at least every person who came through at least got a chance to have this once a year? And they said, yeah, sure, but what, how would we know who got offered and who didn't? And, how would we operationalize that? And just right around that time, the CDC started pushing flu shots. Before it was over 65, they started saying, well, really everyone over 50 should get it. So I don't know, I was sitting around with some friends talking about this, and I said, wait a minute, this is a perfect opportunity because the clinics are all used to this flu shot campaign. This would be a perfect way to make sure a large number of patients, almost all the patients who are in these clinics come in at least once during flu shot season. So if we could guarantee that when they came, at least during flu shot season, they got offered this thing as a campaign along with their flu shot, that would be a great way to engage people. And so the nice thing about that was it seemed more like a manageable thing, a manageable idea to the staff, and people were sort of receptive. It allowed them to get over this thing and learn about it, and still was a lot of work to get it to happen. And then it's, some places it's worked better than others, but what really it led to is sort of like a first step to allow people to work together on this problem without feeling like they had to do everything all at once, 24/7. But once people got experience with it and got some success with it, it sort of spread over. So the ironic thing is that back in that clinic where we used to work, where we were originally trying to do this, they told us they could never do it every day. It is part of the standing orders, and it's incorporated into their electronic health record. And now people are all happy and proud of what they do. They also offer this with flu shots, but they're doing a lot more outreach now. So I think the nice thing about this type of thing is it just shows how you can start the process with something like this, and then if it takes hold, it can lead to a lot of other major things. And at Kaiser and some of these other places, they immediately, now they're calling, this isn't our flu shot clinic anymore, this is our prevention health clinic. So they're trying to offer all kinds of things, like they opened up their mammogram suite during their flu shot thing, so people could just be referred and walk over to the mammogram if they needed one, for example. And this was even crazy things like they were thinking of like having someone who could just walk over and get their pap test, which seemed a little bit extreme to me. Just because you do your flu shot and get directed over to a room where you can get your pap test. But there's a lot of things you could do that way. And of course it's geared by what is the most important public health problem that you want to address. For now, at Kaiser, some of these Kaisers, their screening rates are so high that, although it's always a problem to get people to do FIT tests every single year, they don't actually see colon cancer screening as their highest priority because they're already doing such a good job, and they've actually started focusing on other prevention things to do with flu shots.
Okay, that's great, Dr. Potter. Thank you for your presentation. Thank you for taking us through that FluFit website, too. There's just so many great resources on there. Really valuable to clinicians out in the world. So anyway, now I want to turn it over to Victoria Breton. She's going to talk specifically about the Iowa Get Screened program.
The leader has muted your line. To unmute your line, press #6.
Follow. I'll keep with the momentum here. I work at the Iowa Department of Public Health here in Des Moines, Iowa, and just in the short amount of time that we have here today, we'll talk about a little bit about the colorectal cancer rates that we are seeing in Iowa. It was good to see Dr. Potter's overview of those national rates. And we'll look at those here in Iowa, as well as talk a little bit about the Iowa Get Screened program and the services and resources that we have available to your patients. So here in Iowa, we are seeing that the second leading cause of cancer death is actually from colorectal cancer. The incidence rate, it happens to be the third most common cancer in Iowa. So what does that look like for Iowans in our communities? That's really an estimate of about 590 Iowans are expected to lose their life this year. And this data is from the State Health Registry of Iowa. And they just recently came out with a new report, and so that has some fabulous information on all other different types of cancers as well. About 1,640 are estimated to be diagnosed this year. And you can see the two columns with the new colorectal cancer incident rates in women. That's expected to be about 780. And the male incident rates are 860. So that's pretty on line with what we're seeing at the national level as well. Now, I'm a visual person, and I think these graphs are really a good visual piece to start a conversation about what does colorectal cancer look like here in Iowa. These maps were done by the University of Iowa, Department of Geography. I provided the link there, so definitely recommend that you go out there and take a look at it. It also gets into the methodology on how the data was compiled. But really, just for simplicity, take a look in your upper left-hand corner. You'll see Sioux City on the farthest left map, and that's all red. And what that basically means is that over this period of time, from 1999 to 2010, there was a persistently high rate of colorectal cancer incidence in Sioux City. Now, if you look at the map on the right-hand side, we're looking at mortality data. And so you can kind of see it's blue, and so that means over the same time period, there are relatively lower rates of colorectal cancer mortality. So I think it's really helpful to find out where you live and see what's going on based on the data and then put out in your communities. So just to leave you with some two takeaway facts before we move on to talk about the Iowa Get Screened program. If Iowans age 50 or older had a regular screening, the CDC says about 60% of these deaths could be prevented. That's huge. That's more than half. And so really the importance is, and building off of what Dr. Potter talked about earlier, is the importance of screening so that we can find cancers early and treat them. So the Iowa Get Screened program, we have three areas that we work on. We work on providing direct screening to eligible Iowans. We also promote education and awareness to Iowans 50 to 75, going along with those guidelines that Dr. Potter mentioned earlier. And then we really also encourage policy and system changes, whether that's at the clinic level or at the state level. We promote those. Our overall program goal is to actually increase screening rates to 80% for Iowans in this age range of 50 to 64. And this ties in, again, with the national goal of let's screen 80% of Iowans and people in the United States by 2018. Now, we have our work cut out for us right now in Iowa. We're at 69%. And so in the last 5 years, we've gone up from about 62. So we still have a ways to go, and it really hits home on the importance of screening. On this slide here, you'll see on the right-hand side, we have materials that are developed in English, in Spanish, in Vietnamese. We have campaigns that are targeted to different populations as well. And the neat thing is these resources are free, and they're available to you just by contacting me, and we can send those out to you. They were actually developed through focus groups of Iowans, so they really resonate with your community. The Iowa Get Screened program right now, through June, we actually have 12 screening programs. And they provide case management to actually offer a fit test or a colonoscopy. And so when you have people that come into your clinic, our eligibility criteria is listed here. We serve people that are uninsured or underinsured, and that's usually at or below 250% of the federal poverty level. And then again, our age range is 50 to 64. We'd love to do 75, but just with the limited funds that we have, that's the age range we screen at. And then also not currently experiencing symptoms. So if somebody's experiencing some type of symptoms, the case managers will screen them and then see if they're eligible for our program. So let's look at the next slide here. This is a list of all of our screening sites throughout Iowa. And again, these sites are available through June of this year. We really hope to continue providing these services all the way through 2016. Currently, we're waiting to hear back from the federal government on whether or not we have funding. So at least we know that we'll have funding through June, and then we do have one more year left on our grant to continue providing these services. Let's look at the next slide. I think this is helpful to see the statewide approach that we have. I mean, there are some areas of the state where you can see where we're lacking sites, and it would be great if we could have Iowa Get Screened services provided there. But right now we're in these sites, and let's say you have somebody in Page County in the lower left-hand corner. They could get screened at any of those sites, and so the closest location would probably be Clark. So what happens is that site has additional funding available to provide, to reimburse for, let's say, traveling to that clinic. So resources are available to overcome some of those barriers. Let's move on to the next slide here. Patients can be referred either by calling those screening sites directly or contacting me, and I can definitely put you in touch with the coordinator. So let's do a little polling question here. In your practice, do you use a GLIAC-based test or a fecal immunochemical test to detect basically blood in the stool? And as those are coming in here, the reason I asked that question is again building off of what Dr. Potter talked about, is the importance of having FIT screening in your office. Let's see, the results were 31% said yes, that they do use some type of this form of testing in their office. And then about 69% didn't respond. So that's interesting. About 31% said yes, so that's great. These, again, are some of the same points that Dr. Potter hit on about the benefits of a FIT test. Really, they should be done annually. They're really easy for the patients to do because they can do it from home. And we'll skip through this since Dr. Potter already talked about it as well. And I think we can skip through this slide as well. Just the main thing is your recommendation is what's important. It's the most influential factor, as I think the Flu Fit campaign data has shown in getting a person screened, whether it's a FIT or a colonoscopy. If you have any questions, you can always feel free to contact me. No Excuses Iowa is our website, and if you're going to and enter that in, it will take you to all of our information, as well as we have, again, more social media campaigns targeted to Iowans. And so you can either contact me, my coworker Gina Jones, or go to the No Excuses Iowa website. And here is my contact information, as well as Gina Jones, who I work with as well. And definitely, if anyone has any questions, I know we're right at 1 o'clock.
Thank you, Victoria, for helping to know what is happening here on
The leader has unmuted your
I
line.
don't see any question here. How does your program handle abnormal test results?
So if somebody were to have cancer and they were to find that they test positive for that, we actually have a system in place, knock on wood, we've never had to use it, but we have a system in place with the American Cancer Society to actually get those people promoted to and connected to the services that would be available to treat that cancer. Does that answer your question?
Phone line's open. If anyone else has a question, please let us know or type it into the chat box. I know we're running out of time, but we'd love to be able to answer your questions. You have my contact information there on the screen for Fran. If you have questions and need to scoop, you can email me those, and I can give those to Victoria or Dr. Potter. There'll also be a quick survey as you exit the webinar, and we'd really appreciate you taking a few moments to complete that. Here's another question came in. Please elaborate more on arrangements with ACS for treatment when needed.
So let's say you have a patient who was referred to an Iowa Get Screen site. That coordinator would call us at the Department of Public Health to navigate their client who had that abnormal test result to get them the services that they need.
And this is Lori Graff. I'm at the American Cancer Society, and I think the programs already have in place a referral system. So if, for example, if one of the program locations finds a patient with an abnormal test result, in order to be part of your program, Victoria, they need to have in place somewhere to refer them. Is that correct? Yes. And then you can refer that patient to the American Cancer Society to help with navigation services. So what resources would that patient, once they're identified as a cancer patient and a survivor, are getting their treatment as a result of a referral from that local program, the American Cancer Society can help navigate with other resources.
Yes, exactly. Thank you, Lori.
All right, super. Any other questions out there? I don't see any new ones on the chat line. So, since we're a little bit after 1 o'clock, I think we better wrap it up here. So, thank you for participating. And again, Victoria and Dr. Potter, thank you so very, very much for presenting today during Colorectal Cancer Awareness Month here. All right. We'll sign off now. Have a good afternoon. Bye-bye.